Good day, Dr. Asong and our fellow classmates. My name is Shannon Chu, and my topic is the trauma and stressor-related disorders. First, I will list the types of trauma and stressor-related disorders. Then I'll dive deeper into detail and talk about each of the definition, symptom, causes, and treatment. The 7 types of trauma and stressor-related disorders are post-traumatic stress disorder, acute stress disorder, adjustment disorder, disinhibited social engagement disorder, reactive attachment disorder, other specified trauma and stressor-related disorders, and lastly, unspecified trauma and stressor-related disorders. We're first going to talk about post-traumatic stress disorder and acute stress disorder. These two are kind of similar. It is just a slightly difference in timing. Okay, post-traumatic stress disorder is PTSD. It defines a mental disorder where re-experiencing, avoidance, and intense sadness occur due to witnessing or experiencing a traumatic incident. Acute stress disorder, or ASD, is an intense, unpleasant, and dysfunctional reaction beginning shortly after an overwhelmingly traumatic event and lasting less than a month. If symptoms persist longer than a month, the person is diagnosed as having post-traumatic stress disorder. This means that ASD can develop into PTSD if the symptoms goes over 1 month. So let's say I have acute stress disorder and I'm still showing symptoms at the 3rd month. So that means it's longer than 1 month, right? So that means I'm not having acute stress disorder anymore. I'm having post-traumatic stress disorder. The causes of PTSD and ASD is similar. It is caused by experiencing or witnessing traumatic events. Here I've listed sorts of traumatic events such as war, car accidents, death, violence, abuse, and so on. The symptoms of PTSD and ASD is 1, guilt. Maybe you feel like you're blaming yourself on certain things, or like this person's suicide because of you and you're thinking about it and blaming yourself on it. And then you have flashback episodes or re-experiencing of the traumatic event. Or you will have hyperarousal. Hyperarousal is when your body kicks into high alert just by the thought of the traumatic event. Even though the danger might not be present, your body acts and feels as if it is. So that's very tiring and stressful for your body. And then you will start disconnecting with people because you don't want any social interactions. And at the bottom, you can see I noted something. PTSD and ASD needs to be treated, or it can and will get worse in time. The treatment for PTSD and ASD. Okay, first one, there's eye movement desensitization and reprocessing. This is where you, the client or the patient, will be briefly focusing on the traumatic memory. So think about it, you're talking about the experience or you're thinking about the experience. And then while you're doing this, you'll be simultaneously going through bilateral stimulation. Bilateral stimulation is things like taps, tones, rhythms, hearing sounds, or like the picture, you're watching the movement of someone else's finger. And the psychologist or your professional help will be doing the bilateral stimulation for you. And the whole point of EMDR is to help you eliminate or reduce problematic symptoms. Okay, the next treatment is cognitive behavioral therapy, CBT. Is to help recognize negative thoughts and rewire the way you think. Let's say your friend, Lily, suicide because of her depression issues, okay? And it has nothing to do with you, but then you feel like you could have helped avoid her avoid her from suiciding. So you keep blaming yourself on it, and your other friends are like, hey, it's not your fault, don't blame yourself. So you're like, okay, but then deep down you still blame yourself, and you still feel this guilt. So CBT is to help you really genuinely feel that it's not your fault, to genuinely not blame yourself anymore, okay? And then the next treatment is medication such as antidepressants. Okay, now we're done with PTSD and ASD, we're going to talk about adjustment disorder. Adjustment disorder is a set of symptoms that can show and arise within a stressful experience such as stress, sadness, hopelessness, as well as physical signs. The causes of adjustment disorder is by experiencing or witnessing stressful events. Keep in mind though, traumatic events is more so like watching someone get burned alive or watching someone get stabbed or shot in the head, like really traumatic events. And stressful events is less serious, it's not traumatic, it's just a really stressful life experience. So here I've listed sorts of stressful experience such as breakups, sexuality issues, illness in your loved ones, environmental changes, school or work issues. So you can see there's a difference there. The symptoms for adjustment disorder, first you must note the timing. Okay, my first point here, symptoms must show within 3 months from the day of the stressor. Okay, so from the day of the stressor means the traumatic event. Meaning, let's say an example for me, I have divorce. So divorce is my stressor. So from the day of the divorce or the day of the stressor, within 3 months, my symptoms must show up. And within 6 months, it must go away. If the symptoms doesn't go away within 6 months, that means over 6 months it's still going on and there's no prolonged stressor, I'm not having adjustment disorder anymore. I'm having other specified trauma and stressor-related disorders, not adjustment disorder. So I'll talk about the other specified trauma and stressor-related disorder later. We'll not talk about this first. Just remember, up in 3 months, down in 6 months. Okay, up in 3, down in 6. And then now we're going to talk about my third and fourth point first. Okay, now we're going to discuss the treatments, the symptoms. So the symptoms is like you will feel morose, which is intense sadness, or you will have hopelessness, or you will get more impulsive, Or for your physical signs, you will have skip heartbeats, trembling, twitching, among other physical complaints, of course. And then you will start withdrawing from social interactions. This is the same pattern of a person with PTSD, ASD, and adjustment disorder. These all people, they just want to not have any social interactions. They want to reject all of that, invites they get to, don't want to talk to anyone kind of thing. And then all these symptoms, you can see they are much serious symptoms, right? So then the symptoms are much more serious than others expect. So it's not like normal symptoms. Like, okay, I have divorce. Susie next door also have divorce, but her symptoms is not as serious as mine. She can still work, she can still function, she can still eat. She doesn't have weird physical complaints. But for me, I have like skip heartbeats, and I have trembling, twitching. Now I feel very morose all the time, and I'm like so hopeless all the time. So this is not normal symptoms. So this is much more serious. So I should go get it checked and treated. Okay, the treatment for adjustment disorder is 1, psychotherapy, 2, medication, or 3, psychotherapy and medication. Okay, so psychotherapy is to help assist you in getting back to your normal routine. So imagine you just go through a divorce, you kind of want to just stay in bed and not do anything, and then you have adjustment disorder and you want to not do anything. So this is to help you, get out of bed, go to work, do something. And then next thing is to help you pick up coping skills, which could be helpful for you to deal with the stressful event. And then it will also help you understand the stressful event. Why did it affect you so much? What is your feeling about all this? What is the changes about all this? What do you really feel? So with this all understanding, it's going to give you some closure to get over the event. Okay, now we're done with adjustment disorder. We're going to discuss about the trauma and stressor related disorders in children under the age of 5. So disinhibited social engagement disorder, DSED, is a type of attachment problem in which a child approaches and interacts with strangers in an overtly familiar way. Overtly familiar, not friendly, okay? I'm talking about friendly to the point where it becomes dangerous because they are too friendly that they'll go with anyone ever, okay? And then reactive attachment disorder, or RAD, is uncommon. Remember, it's uncommon because we'll need that information when we get to statistics. But RAD is a very uncommon but dangerous disorder where a baby or infant fails to form a healthy bond with their parents or caregivers. The child tends to reject and withdraw from any love or attention given from their caregivers. So from here, you can understand that DSED is when the child is extra friendly, okay? Reactive attachment disorder is when the child is like, I don't even want your love or attention. It is the complete opposite, okay? And then the causes of DSED and RAD is kind of similar. Okay, one is they were post-institutionalized kids. So they did not have the proper attention from anyone or love or attention from anyone. They did not have any secure attachment with anyone. And then they have childhood trauma, or they have extreme abuse since like a young age, or they were neglected because they did not have any proper love or attention, or their physical needs was not met because they're disregarded. So you can see from all this that the child did not have that secure attachment or bond with anyone because of all these factors. Okay, the differences of DSED and RAD is the symptoms, okay? DSED is where the child is extra friendly to the point where it's dangerous. RAD is where the child is like, I don't want your love and attention. Complete opposite, right? Okay, so these two are far apart. Okay, DSED, disinhibited social engagement disorder, is where the child is extra friendly. So there's reduced reticence. Reticence means shyness or knowing that someone is dangerous, but reduced reticence means that none of that. They don't feel that it's dangerous. They don't feel that this is way too out of their comfort zone. Nothing, okay? And then there's reduced reticence, over-friendly with strangers, and then they are willing to go off with anyone ever. They want to, pack up and leave for a random country tomorrow. Go ahead, someone adopt him, doesn't care. No, he doesn't care. So when he does leave, he doesn't even have the consideration to come and check back on the caregiver. He won't even forget. He won't even remember, like, hey, I think I came here with, like, my family or something. No, they forget they have family, something like that, okay? So the child, over-friendly, and then the reason because of this, scientific reasons show is because the child is craving love and attention. So they're even seeking that from random strangers. And then for reactive attachment disorder, which is the complete opposite, they don't want your love attention, don't want to socialize with you, okay? So this is where there's unexplainable withdrawal, fear, sadness, or irritability. Why do I say it's unexplainable? It's because even in the normal setting, brand new day, no stressor around, nothing bad going on, they're showing these 4 feelings and symptoms. So the parents are just going to go, why are you sad? Something like that. And then they're not seeking comfort or seeking or responding to comfort. So they don't even want the love attention. They're not even wanting it. They don't even want you to talk to them. It's like, don't even look at me kind of thing. And then they are not interested in social interactions. Okay, the treatment for this inhibited social engagement disorder, DSED, is 1, play therapy, is to understand areas where the child is struggling through playing. So you have to understand what's the issue here. And then 2, art therapy, use art as a medium to communicate with the child, to understand the child, to learn more about the child. So it's to assist the parent and child with difficult emotional process. The treatment of reactive attachment disorder. Okay, there's no one treatment, there's no standard treatment for reactive attachment disorder. The only requirement for the treatment, if it is conducted, that it to be conducted with the parent and child together. So they two must be together to conduct this treatment. And the whole point of the treatment is to ensure that the child has a safe and stable environment. You want to give the child that sense of, I'm going to be here forever. Because RAD is developed because they don't have a stable attachment with anyone, right? We've discussed this just now at the causes. So you want to let them feel like, hey, I'm going to be here forever. I'm not going to leave. I'm not one of those nurses that comes here, gets fired, leaves in 3 months, and then bye-bye, and another one comes in, and then the cycle repeats. No, I'm going to be here forever. So you want to let them know like, hey, you can get attached to me. You can want love and attention from me because I'm going to be here forever. So the treatment for reactive attachment disorder should provide them the secure attachment to make them have a positive interaction with the parent or the caregiver, and to make them have an attachment, have a bond with them. Okay, now we're done with the trauma and stressor-related disorders in children. Now we'll talk about the other specified trauma and stressor-related disorders. This category applies when symptom characteristic of a trauma and stressor-related disorder do not meet the full criteria for any of the disorders included in the trauma and stressor-related disorders diagnosis category. Okay, I'll explain here the symptoms. So the symptoms for other specified trauma and stressor-related disorders. You see my left side, I wrote that it cannot be considered as PTSD, ASD, adjustment disorder, DSED, and RAD. This means that, let's give an example so I don't confuse you. Okay, just look at this. Timing of symptom is off. Okay, let's give a character. Okay, let's say there's Billy. I want to diagnose Billy with adjustment disorder, right? But his timing is off. Let's say I see his symptom. Symptoms make sense for adjustment disorder. Causes also make sense. Everything makes sense for adjustment disorder. It's just something's off. Remember how I said adjustment disorder, the symptoms must show within 3 months and down in 6 months, right? Remember I said up in 3, down in 6? But then what if his symptoms show at the 5th month? Or what if the symptoms still don't go away, even though there's no prolonged stressor at the 9th month? So it's off. Timing is off. So you can't really diagnose Billy with adjustment disorder, or you can say that Billy has other specified trauma and stressor-related disorders because the timing is off, although his characteristics or for the other symptoms, causes, everything makes sense, but he doesn't hit the mark for the timing. Okay, the next symptom is there's complex grieving. Okay, now we're going to talk about unspecified trauma and stressor-related disorders. When symptoms are comparable to one of the disorders in the trauma and stressor-related diagnosis category, but the physician lacks sufficient information to establish a meaningful diagnosis, this category is suitable. This is the same situation as other specified trauma and stressor-related disorders. So you can see I wrote this again because it's the same thing. It's just that it's different reasons. So this one is because the clinician does not have enough reason or sufficient information to establish a suitable or concluded diagnosis. So let's say I'll use Susie, okay? Okay, I want to diagnose Susie with something. And then, okay, you know what? I'm going to be Susie. I'm Susie. And then you're the psychologist, okay? So I'm the Susie and I'm on the bed rolling into ER and I'm about to pass out. And I'm like, okay, I think I have symptoms. I have hyperarousal. I have re-experiencing. I have flashback episodes. I have intense sadness. I have these symptoms. And then you're the psychologist and you're writing down the symptoms. But then suddenly I talk and then I pass out. And then you're like, and then? So you haven't finished the full symptoms. So you can't really diagnose me with anything. All you can say is, okay, Shannon has unspecified trauma and stress-related disorders because Shannon passed out midway. So, like I said, clinician does not have enough information, and this is likely to arise through inconvenience, such as an emergency room situation, okay, which I just did in front of you. Okay, now we're going to talk about statistics. Okay, how common or how much people have experienced trauma? Okay, according to the National Council for Behavioral Health, 70% of adults in the US have experienced some type of trauma at least once in their life. Okay, this means it's very common. 70% in 100. So that's like 7 people in 10 people. That's very common. That's easy to find. So it's actually a lot of people are bound to go through some sort of trauma in their life. almost everyone. Someone close to you is going to pass away at some point, or you're going to go through something sad at some point. How common is PTSD? This too is according to the American Psychiatric Association, and according to them, on my left one, an estimated 1 in 11 people are diagnosed or will be diagnosed with PTSD in their lifetime. So this is again very common. Like imagine 11 people in front of you, one of them have PTSD. That's a lot. That's a big amount. That's easy to find. So I'm trying to pass the information here. I'm trying to convey that it's very common. And then the next one, women are twice as likely than men to have PTSD due to sexual assault. This is not even a small gap. Like, okay, it's 20% more than men, 2% more than men. No, it is a whole times 2. So that's very common. And then how common is PTSD? Same question. 8 million people have PTSD in a given year. That's a lot of people. Again, I'm trying to tell you that it's very common because it really is. And then PTSD affects 20% of people who have been through a stressful incident. Imagine 10 people in a bus, rolls down a cliff, and then 2 people out of that 10 people are going to walk out of this situation having PTSD, or like going to have to go through some sort of, trauma things. How common is PTSD in Malaysia? According to an article, Lifetime Trauma Exposure, Gender and DSM-5 PTSD Symptoms Among Adolescents in Malaysia, they said 10.2% of Malaysians show at least one PTSD symptoms. They're not diagnosed with PTSD, they're not fully having all the symptoms, but then they're showing at least one symptom. That is kind of serious also. The statistics for DSED and RED. We'll first talk about disinhibited social engagement disorder. Here it says 20% of post-institutionalized kids have DSED. That is a big amount. Imagine you walk into some foster care or some child home or something, and then there's 10 kids in front of you, 2 of them are going to have DSED. That's easy to find. It's almost like every child care center is going to have it then, because 20%. And then reactive attachment disorder. Remember how I said that RAD is uncommon? I stated that in the definition, remember? And I told you to remember that, because even though it is quote unquote uncommon, right? Even in that demographic, this RAD affects less than 10% of children. So they can't even say less than 1% or 2%. They have to say less than 10%. Even though it's uncommon, if you want to categorize a disorder as uncommon, but then it's still like this common, then it's like, it's just really trying to tell you, hey, it's common. Okay, we're done with all of the trauma and stressor related disorder thingies. Now we'll discuss the infographic poster. Okay, my concept of the infographic poster. You can read the slides if you are a visual learner, but I'll just explain to my own flow and my own feeling. Okay, I choose colorful and bright colors because I want it to feel like you're reading about treatment, you're reading about healing yourself, you're reading about learning and education. It's not really learning about how sad the people who have PTSD are. I don't want it to feel like it's hopeless, and if you have the symptom, you're like gonna die or something, or you're gonna have to go through like 100 years of pain. No, I wanted to feel like you're reading about treatment. You're going to improve and you're going to get out of this state. And then I choose clear fonts, so it's not too cursive, it's not too black or white, it's not blurred, so it's like everyone can understand. And I use cute shapes to group things. So this is a sticker, and this is the words, and then I'll group it with like a bubble, like a square or something. So it's tidy and it's like one set. And then I use stickers because they are pop of color and it's interesting and it's enticing. So if like a kid picks up the infographic poster for fun because like her mom is like paying something and she's like, okay, reading, and then if she see that it's cute, she's gonna show her mom like, hey, it's so cute, look, and then so it's like a little like marketing spice you can throw onto it. Okay, the information in my infographic poster, I did not go through thorough. I just put what should suffice and what is necessary. So let's say like, okay, what's the treatment for PTSD? I'll just put that EMDR. What's the EMDR? And then CBT, what is CBT? And then medication, such as antidepressants. And then the PTSD and ASD needs to be treated or it will get worse in time. So I just write what's necessary and what should suffice. And then you will see why I went quite thorough. And, my infographic was very long. Why did I go so thorough? Well, I'll explain it when I get to the next slide later. Okay, so yeah, my infographic poster is not too much information. It's just what should suffice and what is necessary. And I make it clear and straightforward so everyone can understand. And I use not too deep English. So even though English is not your first language, you still can get what I'm saying. And then I explain what a psychologist or a professional help can do so that everyone knows that what they are going to be going through if they are going to take up the treatment or if they're going to call up a psychologist like the next day. So, and I really encourage them to go and seek help, because some people, they feel like, yeah, so expensive, I don't want to go. And then, this sort of mindset is not good, because it might cost you more harm than good. Okay, my photo and references, my photos and references. I only choose one photo. I did not choose a lot, because I feel like photos don't really look professional. They look like I just search it on Google and just splat it on. It doesn't feel like it's tailor-made for my infographic poster. So that's why I only choose one photo. I prefer to go with sticker instead, because it feels like I hired a graphic designer to professionally make this for me. So it feels like more tailor-made. And then my references, I found from many websites in case to avoid inaccurate information. Okay, now we're going to talk about my statistics. Some may not be as recent. I tried my best to find, but then I cannot find some. And then I cannot find the general one. It's like I cannot find trauma and stressor-related disorders. I cannot find that. But I can find the detailed one, means like PTSD statistics, RAD statistics. These I can find. Okay, and now I displayed how common everything is, so people can feel like they're not alone and they can learn more about the topic. And I explained which is more commonly seen. Let's say like women twice likely than men to get PTSD because of sexual assault, or 20% of children from post-institutional kids have DSED. So I really want people to understand these things and to look out if their friends fit in that category. Like, okay, I have like a friend who adopted a child, so I'll notice more to avoid like if the things or like the disorder gets worse. And I want to make people feel like they're not alone. So I really display how common everything is. How can my infographic poster spread mental health awareness to the public? Okay, I made this infographic poster. I don't think that anyone is really disregarding the trauma and stress-related disorders. My infographic poster is mainly to educate people on the subject, because I feel like some people may not recognize that they have the symptoms. They don't want to accept. Maybe they feel like, hey, I watch people get murdered, of course I'm going to have re-experiencing. Of course I'm going to have flashback episodes. They feel like it's normal, but actually it's not. So this infographic poster is really to let them know the boundaries of normal and serious symptoms that you should go get checked. And then with the information, learning about the subject, they can also help their friends. They can understand their friends, learn what they're going through, and help them emotionally and physically. It's very helpful for their friends, to understand what they're going through. They're going to appreciate it a lot. And I also insert the Malaysian suicide hotline to spread the word that help can be for free. So I want people to feel like they're not on a dead end if they don't have money. So with the Malaysian hotline, maybe they'll get recommended to other places which will offer free treatment. Let's say like, hey, this place gives students free treatment. So then they'll go to this place and find out. So through the hotline, they're going to learn more. So that's why my information was very thorough. That's why my infographic poster was very long, because I want people to be educated in the subject, like really not too deep, but they can have a base understanding. Okay, that's the end of my presentation. I hope that you learn more about the topic. I hope that I explained it well. I hope that you understand and you enjoyed my presentation. So thank you so much for listening, and I will see you in class.